Catch-22 for women. We need to be active for good health, but at the same time, we're up to 8 times more likely than men to suffer an ACL injury.
Female athletes, many of these injuries occur at the high school or college level. Female athletes have a 4 to 6-fold increased risk for ACL injuries when compared to male athletes. There are 2 causes of ACL injuries. Contact mechanism results in the direct contact of an athlete with an object on the field of play or another individual. Contact mechanisms result in about 30% of the ACL injuries in athletes. Non-contact mechanisms result without direct contact of another player or object. Non-contact mechanisms result in about 70% of all ACL injuries, and they include factors that relate to the female, such as anatomical, neuromuscular, and hormonal. Anatomical factors for females are small ACL size and small intercondylar notch size, and wider pelvises. Neuromuscular factors for the female athlete are leg dominance, muscular strength and level of conditioning, quadriceps dominance, and ligament dominance. Hormonal factors of the female athlete includes the fluctuation of hormones during the menstrual cycle and their effect on the ACL. The ACL is one of 2 ligaments located deep to the patella in the articular capsule of the knee. The ACL and the posterior cruciate ligament, or PCL, form a cross in the capsule, providing great support to the knee complex. The ACL functions include maintaining stability of the knee, preventing anterior translation and medial rotation, and preventing hyperextension of the knee. ACL injury description. Most injuries to the ACL in soccer are non-contact and include one or more of the following: one-step deceleration, cutting or sudden change in direction, or landing from a jump. A first-degree ACL sprain results in a small number of microfibers of the ligament torn. Also, a small degree of pain and swelling in the articular capsule and a minimal loss of function. A second-degree ACL sprain results in a few to many ligamentous fibers that are torn, but it is not completely torn. There is a significant amount of pain, swelling, redness, and heat, and moderate loss of function. A third-degree ACL sprain is a complete tear or rupture of the ligament. Typically, there is less pain because of the complete tear of the nerve fibers that run through the ligament. Also, rapid onset of swelling, redness, and heat from the time of injury and severe loss of function and weight-bearing ability result. A common non-contact mechanism of injury includes one-foot deceleration and medial rotation of the knee, causing anterior translation of the tibia and a rotational force. This results in the rupture of the ACL.
During the HOPS assessment, you would identify symptoms such as the knee giving out, a loud popping noise, severe pain in the anterior portion of the knee, no weight-bearing ability, and increasing swelling. Observations would be rapid onset of swelling, redness over the knee area, and altered function such as no weight-bearing ability. Palpate above and below the injury for pain, swelling, and heat. There would be pain and swelling at the knee joint. Make sure to check for pulse and sensation distal to the injury. No special test would be recommended for this injury until they have been seen by a physician. Protect the knee by keeping the leg in full extension using a knee immobilizer. Do not allow the athlete to bear any weight on the injured leg. Rest the knee by removing the player from further activity until cleared to return to play by a physician. Keep the ligaments in a shortened position within the limits of pain and use crutches. Apply ice immediately after the injury has occurred for at least 20 minutes. Repeat icing every 2 hours. Keep using ice until swelling has subsided. Compression is important for management of swelling and inflammatory responses. Keep the knee immobilizer on, or you can use a tensor for compression. Apply distally to squeeze the blood back to the core. Do not leave compression on while sleeping. Elevate the knee. An ACL rupture is classified as a severe injury and requires surgical treatment. The main goal of ACL reconstruction is to restore the physiological functions of the injured knee and to allow the athlete to return to pre-injury sport activities. Return to sport guidelines. Physiological healing constraints. The goal is to reach the highest level of function without risking new injury or further damage to the knee. In order to determine if they have reached the physiological healing, we can use the KT1000 knee arthrometer, the Lysome scale, the Cincinnati Knee Rating Scale, and the International Knee Documentation Committee. No pain or swelling during or after performing activities. Full pain-free active and passive range of motion is needed. To determine if they have optimal strength for returning to sport, we can use the one-leg jump test for distance. We can test their hamstring to quadricep ratio, which should be approximately 3:2. We can also do knee extension, knee flexion, and leg press to determine strength. Proprioceptive coordinative training may improve balance, awareness, and knee control during standing, running, cutting, jumping, or landing actions, and may be effective in reducing the risk of an ACL injury. Maintenance of cardiorespiratory fitness must be at a level necessary for competition. Evaluate relearned movement patterns and sport-specific skills. The athlete should be able to adequately perform jumping, running, and cutting skills. Wearing a brace after ACL reconstruction does not significantly improve the stability, function, and strength in athletes with a high level of activity. Emphasize to the athlete the importance of being patient, learning body awareness, and respecting their limitations until they have healed and progressed properly. Fear of re-injury can prevent athletes from returning to previous levels of activity. Ensure the athlete is psychologically ready before returning to sport. Finally, educate the athlete about the importance of conditioning in the prevention of re-injury.
The program should take 20 to 25 minutes and replace the warm-up. It should be performed on the soccer field about 3 days a week. Intensity should increase as proficiency increases. Technique is very important and should never be compromised. The athletic position should be held at the beginning and end of most positions. Feet shoulder width apart. Knees should not be in front of toes. Knees should not cape inward or engaged neutral spine. The dynamic warm-up includes jogging line to line, backward running, straight leg march, bear walk, and leg cradle. The agility drills include quick feet and the Nebraska agility drill. Jump training includes the tuck jump, which improves control and treats ligament dominance, and the squat jump, which teaches technique during deep knee flexions and eliminates quad dominance. Broad jump and hold teaches proper control while moving forward. 180-degree jump increases control during rotational movements and treats ligament dominance. Scissor jump improves single leg takeoffs and decreases leg dominance. Side-to-side single leg hops increase single leg control and eliminates ligament and leg dominance. Strength training should include 6 to 10 reps of 3 to 5 sets or be held for 20 to 45 seconds. Supine ham bridge increases hamstring strength. Walking lunges increase quad strength. Hamstring rise increases hamstring strength. Single toe rise increases calf strength. Modified plank increases abdominal strength. Abdominal crunch increases abdominal strength as well.
Go.
Flexibility training should be held for 20 to 30 seconds and to the point of mild tension. It should include a hamstring stretch, hip flexor stretch, quadricep stretch, and a calf stretch.